George, welcome. He's a frequent participant in TB Echo. George Hampton has been with the Public Health Seattle-King County TB Control Program for 12 years and has never seen challenges like the current one. George is going to share experience and offer time to ask questions on how the team at the TB Control Program DOT amidst COVID-19. So thank you, George.
Thank you. I don't have any interesting slides, but I'm going to try to be quick so you guys can get back to some more questions if you would like. So I'm just going to talk about DOT, a little bit of what it is, how we do it, and then how that's changed, and then an example of seeing a patient in that new environment. So DOT is basically directly observed therapy where an outreach worker watches someone take their medications and then records it once they've done that. It's been around for a long time. At our program, we have 3 outreach workers, and we have split the county into 3 sections. Today, there are several ways to achieve the goal of treatment, which is in-person DOT, which is classic directly observed therapy. You see a patient at a predetermined time and place, observe and transcribe them taking their meds, and then they're seen once a month at the clinic and are also at that time given their refills. There is virtual DOT, which is done on we register them for a computer app, and then they're able to take their phones, download the app, and then record a visit, and that date and time of that visit is stamped on it. It uploads, and then later we're able to download it and read it. Those people are also seen in the clinic once a month and given their refills. And finally, self-administered, or SA, someone who takes their medication on their own and they're trusted to be compliant. They're also seen once a month for labs and refills. The determination of which process of DOT is used for a particular patient is done by the managing provider. And then as they go along, sometimes they get input from the team during the process. And what they pick would be the type of TB the patient has, or their ability to tolerate the medication, or behavior that could affect adherence. I personally feel the #1 way to achieve adherence is by establishing a solid relationship with the person you're seeing. Trying to get as much information as you can before you go out there. You know, what gender are they? How old are they? Do they live in an apartment or a house? Are they by themselves? Are they working, retired? Is there one family, or are there several generations in there? All those things can help you connect if you are prepared. When I get to their home, I'm a big guy. So when I come in, identify myself, have my little ID and all, I come in and I take off my shoes at the door, and then I have a seat so that we're doing an eye-to-eye encounter and they're not looking at me and my size. But today it's a little different. With COVID, there are many different challenges. A lot of the people we have with being seen those 3 different ways, they had to change it. The big thing now is less exposure. So we had to move patients to different forms of treatment, and that meant that more people were getting virtual DOTs and more people were being SA'd, and we still had a group who weren't able to do that for whatever reason. They couldn't be put on either one of those, so they were still being seen in person. But by moving that around, it got it so that the 3 of us were able to work differently. We were able to do all our charting and stuff from home. And then we used, using a baseball analogy, the person that's seeing the most patients is the major league guy. The one that's seeing the second group, which are people who are either still working, or so they have to be seen in the morning, or they can only be seen during the lunch break, and then some of them are seen later in the day. That's a smaller list, so that's the minor leagues. And then the ones that are being seen either self-administered or on virtual DOT, that person who's covering that is considered to be on the bench. And they strictly work from home. So when you're going out now to see patients, you may find that they have a contact, or they were tested for COVID-19, or they're awaiting results. And also when you go out and see people, you're looking very different. You have, first off, when people are walking around during the day, they're wearing a mask. everybody's got a mask on now. No one is not wearing a mask. When you get to their house, of course, you're going to want to put on, as a healthcare provider, we get fitted once a year, fit tested for our mask. And I personally wear what's called a P95. So I've got that on. Okay. Then I have to put on my gown. And okay. Now, mind you, you're doing this outside of your car, out in the parking lot, so people aren't sure what you're suiting up for. Then you got your gloves. And finally, you have your splash shield. So it's a very different look when you show up at somebody's door for the visit. Whole different ball game, a little different to establish the relationship, but I guess you just have to use eye contact. So once you get there, you're talking to them, and the first thing you're doing is doing a symptom check at the door. Have you had any of these symptoms in the past 14 days? A fever greater than 100 degrees, difficulty breathing, dry cough? And if any of that is yes, then you want to reach out with your handy lifeline and call the case manager and let them know. If not, then you proceed. Now, in COVID, you don't go in the apartment anymore. You just stand by the door, and they bring their medication to the door. You ask them if they're having any symptoms with their meds, any reactions, and then just proceed. But every now and then, it is necessary to go inside. And this is where I'll talk about my experience with my patient. I was seeing an 8 or 9-year-old girl. She's a Pacific Islander. And she was, at the time, I was told that she had had a COVID test, but we didn't have the results back yet. So I had to suit up as I demonstrated. And because she's a child, I had to go into the apartment because she had just finished a drug challenge and she was starting on her full regimen. So with kids, especially that age, sometimes they can or can't tolerate swallowing the meds. So in her case, she couldn't, and we were crushing them. So I had to come into her house and sit down, and in her kitchen. And we're sitting at a table that's against the wall. So we're facing the wall. There's a wall here, one in front of us, and then to the back of us is the rest of the room, the kitchen. And I'm talking to her while I'm crushing those meds, telling her, today we're going to take the whole thing. She was a little worried about it. She wasn't sure she could do it, but just reassuring her, as you do with children, while I'm crushing these meds. Also, you can use OraSweet or chocolate syrup. I had chocolate syrup, so I'm doing that and trying to get just the right mix, not making too much, but just enough so that the bitterness of the medication is subdued. I'm doing that, and one of her little siblings saw me come in and went to the back and then brought out some more of the family. In this apartment, several generations live together. So I'm sitting there, crushing the meds, suited up, trying to make eye contact with her and establish, because she's not someone I normally see. And as we're doing it, the grandmother comes in and she sits down. Then another person comes in, and there's an aunt that does speak English. And she is asking me questions. What's going on? What is this new thing that's happening? Why aren't the stores open? And I says, well, we don't really know. It's an ever-changing situation, but the best thing to do is make sure good hand washing and face washing. And I'm still talking to the kid, trying to convince her to do what I want. Now I've got the meds ready. I give her, it comes down to about 2 teaspoons. So I give her that first teaspoon and she looks at it. She doesn't know if she wants to take it. And so now I'm cajoling her while I'm being peppered by questions with the rest of the family. So as this moves on, maybe 10 people are now in the room. They're all standing there. And I'm starting to have a little bit of an inner anxiety attack, because I'm just like, wow, or just really nervous, I would say. Just like, wow, there's so many people in this room. This is taking forever. She's not going to take this medication. And they're all talking. So only the aunt speaks fluent English. The rest of them are asking her in their language what's going on. So I get the little girl to take the first bite. She followed up with a little piece of melon. And then they say, well, how long do you think this is going to go on? I have no idea how long it will go on. Well, what do you think we should do? What should we do? And I I was sitting there thinking, well, all that was happening, why don't they know more about it? Maybe maybe they don't have and I knew they had access to a computer because the child was doing her work from home. So I just told them, you should go to the public health website, and they have it in other languages there. You can read up on it. Meanwhile, good face, hand washing your face, making sure you stay away from people 6 feet away from folks who aren't in your household. And anyone who doesn't live here in this apartment, you really don't need to have them in here or be any closer than 6 feet. And in their culture, they not only live multi-generations in an apartment or house, but they also move in between those homes, and they may stay the night, go home, come back. So that's really kind of tone-deaf advice for that particular culture. But you just, do the best you can. And finally, we got the teaspoon down. I got the second teaspoon in her. And by this time, I'm just completely like, oh my gosh. And they're all on me, asking me questions. I said, well, we're done here. You should give me a call. I was just completely like, inside, but I was really calm. I tried to keep my connection with her and left the house. Got back to my car, and man, I opened the trunk, took all the stuff off. You have your hand sanitizer, of course, and of course my Santa Claus for wrapping everything down, and just took a moment to kind of get my breath back. But they're just as, they don't know either. And as a person who does this, people who are in public health aren't doing it for the money. They're doing it because they're genuinely interested in the public good. But it's like a new challenge. But I went on to the next person, and, I suited up for them if necessary, or just had my mask on. I think one thing that's an advantage now to where we are with COVID, particularly with the daily wearing of masks. Now when you go see patients, in the past when you went out to see people, they're like, oh, what's that car doing here? And what's that guy doing with that mask on? But now everyone's wearing a mask, so you fit right in. And that's about all I had. Was anyone had a question?
There's a question in the chat box. I don't know, Dr. Horn, if you can read that.
Sure, I can read it. Thoughts on challenges with stigma with healthcare workers in PPE at the door on home visits?
Well, as I said, you fit in a little better, but when you show up, it's just, they know you're coming. And then again, trying to make a connection. When you're totally suited up, it's difficult. Otherwise, as I said, I come in, I reduce the impact of myself, and then I'm able to make the connection. With this stuff, I'm generally not coming in unless there's a child in there. So you just have to use your A game. If you're seeing patients, you know that you got to put them at ease, speak clearly, and let them know that you're there for their best interest. And there is cultural issue, because usually the patients that would have an issue with you being there, they're surrounded by their people. People kind of, can't think of a better word, I want to say ghettoized, but they kind of get themselves all together in one spot. So everyone around you is from Africa, everyone around you is Marshallese. With African culture, it's a little tougher because they definitely have a mindset of disease. That person is sick, so they need to stay back from them. But you just have to get in there. That's why the relationship piece is so important. You get in there, establish you're there for their best interest. And when other people ask you, because people will come up to you in spite of what's going on, even before and now, come right up to you. What are you doing here today? He says, well, I'm here to see them, to make sure everything's all right with them. And because of that, you should feel good because this is getting taken care of. And if I were seeing you for something, wouldn't want me telling everybody else in the building what I'm here to see you for, right? Yeah, okay. So it's all good. And have a good day.
George, we have another question. Do you have space to wash your hands? How do you dispose of your PPE?
So I have a county car. It has a hatchback on the back of it. It's a Ford hybrid. And so when I get back to the car, I take everything off into the back of the car. And then I'm able to, once it's off of me, and I have a spot that I put all the contaminated stuff in, and the fresh stuff is, clean, dirty, old school. Put all that here. Then once it's off, I use my hand sanitizer. I just shut my trunk. And then I'm able to go to my front. I don't have soap and water in the field, but between my Santa Claus, they come in the big round tubs. We have the clinic. I just put a bunch of them in a Ziploc bag so they stay nice and wet and effective. And the PPE, I'm pretty well schmoozled and shellacked up by the time I'm done.
There's a comment. Thank you for doing this important work. And then separately, there's a question. Do you often have an interpreter with you?
So no, I never have an interpreter with me. What I do have is access to a thing called Voyance. So I call in, put it on speakerphone, and then once I have the language, I just lay it down. It's on speakerphone, and we talk with that with us in the room.
Have you had any patients that have been known to have COVID?
There is someone actually now who I will see tomorrow. This person was suspected. They didn't have the results of their test back. Their test did come back negative, which is cool. But tomorrow I will, and I'll be using all the things I showed today.
And will you be going into the house or like staying in the doorway?
I don't have all my information yet on that person, but if it's an adult, I shouldn't have to go in there, and it'll just depend. If they're elderly and they're all the way in the back of the house, they can't come to me, then I may have to, yes. Or if it's a child.
George, there's another question. Do you count the PPE before you go into the field? Do you know ahead of time how many people you will be visiting to get the PPE available on hand?
So correct. When you're setting up for your day, you're going to look at who you're seeing and who it is. We have a sheet that is, particularly now they're working this new way. In the old days, you had everyone established and you would just, set up each day. But now we have a sheet we do at the beginning of the week. So whoever's doing whatever level of seeing patients, go through that. We have a discussion in the morning. We have a huddle. And then we discuss whatever's going on with that person. If there's someone who has it, then you would prepare for that. I have one set of everything that stays in the back of my car. I brought some things home here today just for my little visual. But depending on how many of those people fit that, I would bring more sets.